There may be more of you who filled it in this morning. Thank you to everybody that has filled it in. This is only what I had last night when I was trying to put this together at the ordinary hour of 11 or whatever. So first up, it's part of your role. Now for you guys, the vast majority of you say for alcohol and tobacco, absolutely part of my role. 3/4 for the pharma, opioids and benzos, less for cannabis, and less than half think that asking about and helping your patients with tobacco, with ice, cocaine and heroin is part of your role. However, 96% of you see patients with drug and alcohol issues at least monthly. So it's really common, yeah? Okay. Alcohol and tobacco, you guys are pretty comfortable asking about it. Not so comfortable looking at opioids and benzos, and much less comfortable with the illicits, and particularly ice and cocaine and injecting drugs. Not real comfortable with that. How often are you screening? Vast majority of you said when I think they've got a problem. Others said, look, alcohol and tobacco, much more likely to be every time I see them or every year. Much less likely to ask people about their other drugs. Now, one of the issues we have with doing it when you think they've got a problem is that quite often people don't come in saying, doctor, I need your help, I need to reduce my drinking. They do, but quite often they'll come in with something else. So unless you ask them, you may not know that they've got a problem. Okay, confidence across the 5 A's. We're going to be talking in the next few minutes a little bit about what the 5 A's are. But it's basically what we do when we see a patient, that we ask questions, we make an assessment, we give advice and information, we put together a treatment plan and we sort out what kind of follow-up they need. Strongly agreed that you had high confidence treating alcohol and tobacco. Interestingly, tobacco was a little bit lower than alcohol. And lower rates for the pharmaceuticals and even lower for the illicits. Now, what we find is that generally the graph does this. So you start off, yeah, look, I'm pretty confident asking, but when it gets to knowing what to do, I'm less confident, but I'm a little bit more confident about what I do to refer or how I follow up. But generally with the alcohol and tobacco, it's pretty high levels, and with the others, it goes down. Oh, okay, big graph there. One of the things just looking, and I know this is way too much information, but if these two here, these big red ones and pink ones, are your alcohol and tobacco and alcohol, and really high levels there. And you can see with the others, you're much less confident. Who are you asking? More than half of you have said, yes, I've asked for advice. And who are you asking? Most likely your colleagues in the GP setting. So 1/4 of you said, I asked my colleagues. Local drug and alcohol service, probably about 22%. So that's pretty good. That information is you're talking to your local drug and alcohol services, and what we're hoping from today is that you'll be more confident about who to go to and who to ask in terms of services. Your PHN, some of you are asking, but not many. Online resources are a really important part, but also your psychologists and your psychiatrists, so that you're asking them questions. Now, one of the issues may be that while they might be really skilled in mental health issues, they may not be so skilled with drug and alcohol. So, you may well have a psychologist or a psychiatrist that is easily available and really gets this stuff, but you may not. Okay, just to set the scene, in terms of using drugs and alcohol, not everybody is going to have a problem with a drug and alcohol use. So it doesn't necessarily mean that you need to do something for everybody, but you need to think about it and think about, well, what's the risk for this individual and what information do they need? I take issue with the idea of moderate consumption of red wine. That this is somehow a benefit, and I get it. It's a nice thing to do. It tastes good. It's part of that social interaction. But the benefit is really, really small. And in fact, when you look at the new data about alcohol and its risks in terms of cancer, I think that's pretty well struck out. And I remember going to a talk some years ago where the person said, well, yes, maybe there's a little bit of red wine can just improve, is beneficial, but you can get the same benefit from going from a 15-minute walk once a week. So it's not a huge amount of benefit. Then you have people that are potentially using drugs and alcohol in hazardous or harmful ways, so that they're at risk of harm, or they've had some harm, or they're actually starting to develop a substance use disorder. And included in substance use disorder is this idea of dependence. But you don't have to be dependent. You don't need to have physical tolerance and withdrawal in order to have a substance use disorder. Yeah? So this is the spectrum of presentations. Okay. And just looking through this, so this is the 2016 household survey. 12% smoked, 17% drink alcohol at risky, hazardous or harmful or dependent levels, and 15.6% had used illicit drugs, and this includes pharmaceutical drugs obtained from friends or on the street or whatever. So quite low levels. In terms of pharmaceutical misuse, 4.8, that's the big one there. Cannabis, cocaine, ecstasy, methamphetamines, quite low levels. So you're less likely to see those, but they do come up, and in some communities, they are a real issue. Okay, so in general practice, and these are a little older, but you know, nearly 14% daily smokers. Others were occasionally smoking, and more than a quarter had previously been smoking. 23% drank at risky levels. 62.7% were overweight or obese, and around 50% had at least one of the above three, if not more. So we are seeing people with issues around lifestyle, including drug and alcohol issues in our clinical settings, and they do cause harm. That's from the Beach data, which is collected from GP practices. So the 5 A's, and you've kind of, if you did the online survey, you would have come across this. The idea is that the ones that I use come from the RACGP's SNAP guide, and some of my registrars will say, yeah, I snapped that patient. And perhaps for us older people, we may not have had a look at this. It's a really nice book. It's available on the RACGP website, so just put RACGP SNAP and you'll find it. And it uses the 5 A's, ask, assess, advise, assist and arrange. Now you may be going, oh God, not another the group of words that I need to use. They are the same as what we do in terms of taking a history, doing an examination, putting together a management plan and creating follow-up. They're the same things, it's just put in this nice little mnemonic. If it helps, if you think, geez, I've got this person drinking, what was that thing that Hester said? Oh yeah, ask. You know, so if it's helpful, use it. If it's not, let it go. Okay, now I wanted to just play a video from our colleague, Dr. Liz Sturgis, who is a GP down in the ACT. And there's a nice little video, if I can work out how to use it.
As GPs, we're often involved in helping people change behaviours that have become part of their everyday life. The 5 A's is a model that helps us think about a consultation and how it might work with the patient. The model's been used to help patients with their smoking habits, physical activity levels, nutrition and alcohol intake, and we can also use it when we're thinking about helping people with other substance dependence problems. When I'm thinking about helping patients change their behaviour, this kind of picture really comes to mind. So a ladder that's really, really, really high looks like it's very difficult to climb, and it looks like it's probably going to be easier with someone helping you along. But the ladder is a little bit too straight to really represent what happens when we're working with a patient. As GPs, we know that usually behaviour change looks like a couple of steps forward and a few steps back. It's not this straightforward path. And the 5 A's is a simple acronym, but it's not a simple process. I once taught a bunch of medical students and I was a bit shocked to hear them say, oh yeah, that behaviour had changed stuff. The 5 A's stuff, it's very easy. And they moved on to the next question. So I don't know about you, but I find it really hard to remember what each of the 5 A's stands for. For some reason, even though it's a really simple acronym, I cannot remember which verb starting with A each part is. Hopefully we can go through things today and you can see that the important thing is not remembering which verb in the exact order, but the process that's really important. The 5 A's model was developed in 1996 by the US Department of Health and Human Services. They started the model to help people stopping smoking, and they based the model on the stages of change model, which most people are familiar with, where a patient might be pre-contemplative, not wanting to give up smoking, right through to thinking about changing, actually stopping smoking and through into maintenance with possible relapse. Often the 5 A's is presented like a bit of a checklist that you move from one side to the other, from ask to arrange, and bingo, your patient is fixed at the end. However, in practice it really doesn't work like a checklist. at each consultation, the patient may need more or less of different parts of the process than others. And the important thing is to work out what your patient needs at that particular consultation. And that really brings us to the fact that having a good working relationship with a patient will help you help them change behaviour. So by a good working relationship, we mean where the GP and the patient can collaborate on the goals that are being set, that they agree on the right way that they want to work together to reach those goals, and all of that happens within a respectful relationship. So let's go through each of the parts of the model. So the first A is ask. And what are we going to ask the patient? And really what this step is about is seeking permission from the person to talk about the health behaviour. And this is an essential part to make sure the person is comfortable talking about what you're thinking is important in that consultation. So the next A is assess. And while we want to look at different parts of the particular health behaviour, we want to do it in a really holistic way. So we want to think about the person's readiness for change. Are there any particular barriers or opportunities for change? Is the person living in an environment that's going to be supportive of change? And as a GP, we're usually aware of their social and cultural background. Are there any new emotional issues that might be really important? So thinking in a really holistic way for that assessment. The third A can be different depending on which part of the world you're from. So in Australia, we think about it as an advise, agree, combined category, but it's different in the US and Canada. So it's good to see it's not only us, it's the experts too that get a bit mixed up with the A's. So in this third step, we're talking about setting collaborative goals with the person. Where do they want to be with their health behaviour? Where do they see themselves going? And it'd be good to do these goals in a smart way. So that we were talking about a specific, measurable, achievable, realistic and time-based goal. So instead of thinking, my goal is to be fitter, it'd be better to say, my goal is to go walking 3 times a week for 30 minutes with John at 6:30 in the morning. That'd be a much more measurable goal. As part of this stage, we also want to look at informing the patient. And that's meeting the person at the level they're at with the information that they need. So depending on the patient's health literacy, their background, what they already know about the topic, it's going to be really different types of information we might offer them. So the fourth A is assist. And really, in GP speak, this is talking about forming a management plan. So now that we have collaborative goals with the person, how are we going to set about reaching those goals? We might need medications, referral to allied health, or lifestyle changes. And the final A is arrange. And what this really means is how we're going to put the patient's plan into place. An important part of that plan is following up with the patient. When do we want to see them again? When do we need to touch base? This is really important so that they don't feel you've palmed them off to another place and are not caring about what's going on. And that really comes back to that respectful working relationship that's key to good general practice, that you know the patient and their context, their family, their community, and that you're really ready to work alongside them on a journey that can sometimes be really difficult. It's a good time to reflect on the principal characteristics of general practice, where we're trying to work in a person-centred way, in an ongoing fashion, looking at everything that's affecting that person's health and coordinating their care, and looking at all of their health issues, not necessarily just the one that they're presenting to you. And this pattern of work really does work with that 5 A's model and thinking about behaviour change. So sometimes the 5 A's model is presented like this streamlined approach. You start at one end, you end at the other, and bingo, your patient has changed. But we really know that's not the case. And when we're thinking about the 5 A's, being more flexible in which parts we bring into the consultation, the bits that are important to that patient, is very helpful. However, we always need to remember that asking permission and making sure it's okay we're going on this conversation with the patient at every consultation. And really, that's one of the big benefits of being a GP, in that we work with people over time. We don't have to do every little bit of that model at the first consultation, we can work with that patient over time, working through all the different processes till we come up with a plan and goals that that person's happy to work with. And if we think about the ladder picture that we started at the beginning, I actually think this picture represents much better working with a patient on behaviour change. You can see the spiral, sometimes on an upward spiral, sometimes circling downwards, staying with the person over time. And our aim is always to keep travelling in the direction of the patient's goals.
Great. Okay. So we are running a little bit late because we started late, so I'm going to try and move through my section quite quickly to make sure that Jenny has time for her session before morning tea. But one of the things I just wanted to kind of get a bit of a sense of for you guys, how do you feel, how do patients feel about asking about their alcohol and smoking and other drug use? Yeah? Do you think they're comfortable? Put your hands up if you think they're comfortable. Not all the time. Sometimes comfortable? Yeah? How many people would say sometimes? Uncomfortable? 50-50. So for most of you, look, there's sometimes when they're comfortable, sometimes when they're uncomfortable. How about you guys? How comfortable are you? Super comfortable? Super uncomfortable? Sometimes uncomfortable, sometimes comfortable. Yeah, I'm super uncomfortable sometimes. Yeah. Okay. All right. And so as Liz said on her video, the first one is giving permission. Now, if I see someone in a drug and alcohol setting, they expect me to ask about the drug and alcohol. That's why they're there. It'd be weird if I didn't. But in a general practice setting, it may be that they've come in about their cold and you've noticed that you think they might be a smoker, or they've come in with high blood pressure and you're thinking maybe they're a drinker. But maybe you need to set the scene. So a really important part of that is normalising it. As your GP, I'm really concerned about lifestyle issues, including weight and exercise and nutrition and alcohol, smoking and other drugs. Is it okay if I ask you? So you're setting the scene, you're normalising it, this is part of my role, this is what I do, and is it okay if I ask? I've never had anybody say no. I've had a few people go, oh, Hester, I'm running a bit late, can we do this another time? Or say, next time, yep. Or who's going to know? Who are you going to tell? What's going to go in my notes? Yeah? So those are important issues to think about, and to think about how do you respond to that? How do you deal with that? And it may be that the person going, look, I've got to go pick up the kids. Okay, that's fine, we'll talk about it next time. And it may be that what they're doing is politely saying no, but you put a little note in your file and next time you come in, remember we spoke about that last time? You've got time today. So once again, it's you as the practitioner signalling to your patient, I'm okay with talking about this stuff. I may not know everything, but I'm really okay with this, and when you're ready, I'm here. I'm open to it. And it may be that they don't then start the conversation for another 6 months, but quite often they do. The other thing, looking at the research, the evidence in terms from patients' point of view, is they kind of do expect us to ask, and they trust us. GPs have a high level of trust in the community amongst our patients, and we see 86% of the community every year. Okay, so what I want you to do quickly is turn to your neighbour and do the ask. So set the scene, normalise it, explain while you're asking, and then ask permission. So with you, in groups of 2 or 3, turn to your neighbours and just practice. Do it in, 10 seconds. Have a go. Do you want to do it in a 3? So you're explaining why you ask about lifestyle issues and you're asking permission. And then swap. All right, guys, I'm going to stop you there. I know we could spend a bit more time in this, but I am aware of the time. So once again, that simple thing of, how much do you drink? When do you drink? What issues do you have with your drinking? We'll talk more about that as we go through the day, so that you really, by the end of the day, if you haven't already, you've got a really good idea of how you actually have those conversations with your patients. Okay. We've talked a little bit about the patient-reported assessment or outcome measures. Now this was, I really like this slide. I like little infographics. This is about obesity, so it's about weight loss. Now what they showed was, all you need to say with weight loss is, while you're here, I just wanted to talk about your weight, said the doctor to their patient. A little bit of talk about the weight, spent 30 seconds advising patients on a good way to lose weight and referred them onto a program. Now this is in the NHS, so unfortunately you don't have access to this program here. But what it showed was that it took 30 seconds. 40% of those people attended. People lost weight. 25% of them lost 5% of their weight, and 4 out of the 5 agreed that the conversation with their doctor was appropriate and helpful. So it didn't take a whole heap of time. It was very simple. Now, I know sometimes the way that people present with their drug and alcohol and their lifestyle issues is not that simple, but it is possible to do it in a short space of time. Okay, so assess what, how long, how taken, how much, how often, what concerns, any harms, any risks, any health effects. As Liz said, do you want to change your use? And can I help you? So those questions to give you a bit of sense of what's going on for people. And if they say, mate, doctor, don't really want to change what I'm doing, you go, okay. Can I give you some information about the risks? No, I know it all. Okay, that's fine. Letting you know I'm here so that if you're ever ready, if you ever want to, come and have a chat. And I usually say something like, yeah, but I'll continue to pester you because I'm worried about you, or something like that. Okay. And they assess that biopsychosocial assessment and with a non-judgmental approach. So think about the language that you use. And it may be that you come from a background where you've not had any experience with drugs, or where it's a background where it is culturally frowned upon. Unfortunately, shaming people and stigmatising language doesn't actually assist people to be open about what they're doing. And so really important to be thinking about that. And even if and beware about your own cultural and moral biases. And it may be that in the end you decide, you know what, I just am not the best person to be dealing with this. So know where to refer the person. Know, you know, is there a colleague in your practice, or or are there options in terms of external referrals to assist that person? Okay, so advise and agree. Once again, as Liz said, it's about brief advice, it's about goals, it's about sorting out where they're at and what they want to do and helping them make those smart goals. Assist is really about treatment, so options for treatment, the pharmacological and the non-pharmacological, and we'll be going through that in more detail. Withdrawal versus abstinence options, and looking actually at managing other health issues. Very commonly drug and alcohol issues exist with mental health issues and with other physical issues as well. And then arrange, as we said before, it could be, I'm going to follow you up in a week. I'm going to send you to my colleague. So these are the options, the online options, the self-help groups. These are the referral options in the local area. And another really important part of this is somebody is having issues with their drug and alcohol use is sometimes one conversation can be enough. I can remember some years ago a patient of mine that I just had a brief chat about the amount that she was drinking, and off she trotted. You know, it was a 30-second chat. We're dealing with something else. She came back 18 months later for her pap smear, and I just said, oh, by the way, Hester, remember how we had that conversation about alcohol? And I went, I don't remember, but yes, I remember. And she said, I've stopped. You know, so from that one conversation, of course, it's not, I wasn't magic, I didn't wave a magic wand and make it go away, but even that one conversation sometimes can assist people to move on to what they want to do. She was already thinking, she was thinking about it, but having her GP, who she trusts, who she has that therapeutic alliance with, suggest to her that it might be a good idea to do things differently, allowed her to do that. Okay. I am going to leave this just very, very quickly, that there is good evidence that brief interventions, that the 5 A's, that this approach actually does make a difference and can work in a general practice setting. I'm going to leave that. So really looking through this, there are barriers to us doing this, and very commonly it's time. I don't know how to do it. I don't know if my patients want to do it. You know, and the system, the fee-for-service system can be an issue. If I find this, where do I send them? So one of the things today is for you to really kind of understand where are the options that you can send your patients. We'll move on from that. And now we're going to go to Jenny. I'm almost got it on time. So Jenny, you're going to come on up and talk to us about motivational interviewing, and there is going to be a role play between 2 actors where you'll be able to observe some of the techniques that you use in motivational interviewing.